Well, good morning. Good morning, everybody. This is a fine morning with a little bit of humming. I am introducing today two brilliant individuals in my program, our institute, for our ICOS seminar series. So welcome. Our first speaker today is Smith Giri. And the way we've structured it today is to give you highlights of some of the presentations that had been made at national meetings, national oncology meetings. So the first speaker is Smith Giri. Smith has had he's traveled, he's climbed many mountains to get here. He comes to us from Yale most recently, but he completed his MD at the Tribhuvan University in Kathmandu, Nepal. Went on to the University of Tennessee to do his residency and then his fellowship at Yale, and then joined us. And has been an assistant professor in the division of Hem-Onc, Department of Medicine, and a member of the Institute for Cancer Outcomes and Survivorship. Most recently, he is enrolled in the PhD program for cancer epidemiology outcomes and research at the School of Public Health at UAB. Smith is just, I have to make sure that he calms down and slows down just a bit. He works extremely hard on a variety of topics, but the underlying themes to all of those topics is hematological malignancies, outcomes with a focus on the geriatric population. Smith, as I said, I have to make sure that he slows down a bit. Testament to that is the fact that he has, Smith, hold your breath, 86 publications to his name thus far. I don't know when he does that. He has a wonderful daughter. He hasn't slowed down with that even, and I'm hoping that he'll show us a picture at the end. And with that, I give the show on to you, Smith. Go on.
Thank you, Dr. Bhatia, for the kind introduction. Very happy to be here today. It is really a privilege to be able to speak to this audience. My topic today is I'm going to focus on two projects that are related with each other with a broad theme of using an electronic health-derived database to study real-world outcomes among older adults with cancer. These are my disclosures. Most importantly, I am an aging researcher, but not really a board-certified geriatrician. My agenda for today is I'm going to briefly talk about real-world data, since all the talks today are broadly centered around use of real-world data to understand cancer outcomes. I'm going to introduce the Flatiron, a relatively new electronic health record-derived database. And then I'm going to touch upon the two projects that were presented in 2020 American Society of Hematology meeting one by one. And lastly, I'll touch upon some of the future directions that my group is taking pertinent to this area of research. So what is real world data? So the FDA defines real world data as any data that is collected relating to patient health status and or the delivery of healthcare collected during routine clinical care. So what is not real world data is any data that is collected as a part of research. So clinical trial data or surveys and trial data that is directly collected during routine cancer care delivery is really a real world data to study cancer outcomes. So we traditionally tend to think of claims data being the source of real world data. And when what happens when we routinely see patients in our clinical practice is we submit a limited amount of clinical information along with the billing claims, and that gets captured by the different insurers like Medicare and Blue Cross Blue Shield, which is then made available to researchers to study cancer outcomes. As you can imagine, the amount of clinical data in these kind of claims data is fairly limited. The next one is electronic health records. Here, we're talking about direct clinician records of patient clinical status and clinical information, which is captured in electronic health record system like Cerner and Epic, Cerner being the system that we use here in UAB. And that has really come along in the last 15 years as it is becoming increasingly common to use electronic health records to store patient data. Last but not the least, there are some companies out there that also capture patient-reported outcomes as a part of routine clinical care delivery, and that is another element of real-world data. Flatiron is a company that partners with many different clinical care sites across the country, and by assimilating the clinical EHR data from all these different sites, it has created this huge database of almost 2.8 million patients treated for cancer across more than 800 sites in the US. What Flatiron does is it partners with each of these hospitals and clinics and extracts all these electronic health records, which includes not just the diagnosis and the visits, but also labs, therapies, and physician notes. And by processing this data and harmonizing it, standardizing it, and cleaning it, it generates this real-world evidence database. There are different longitudinal data sets available for researchers. One of those is multiple myeloma, as you can see, but there are other solid and hematologic malignancies available for researchers as well. Importantly, this data is very recent, with up to a 30-day recency period. So data cut around August or July can be found if we requested the Flatiron data today. There are different types of data that are available, including demographic, insurance data, as well as treatment-related data, importantly, the line of therapy, the medication administered, the laboratory data that is collected during routine cancer care, as well as cancer-related data, including pathology, biomarkers, next-generation sequencing data, and lastly, outcomes data in terms of survival, as well as progression. So this is in brief about Flatiron. Now I'm going to talk a little bit about some of the projects that we've done utilizing the Flatiron database. Project number 1. We studied, and the title of the project is Association of Pretreatment Neutrophil to Lymphocyte Ratio with Frailty and Survival in Multiple Myeloma. Why did we do this research? First of all, multiple myeloma is a disease of aging. Median age of diagnosis is 70 years, and as shown in the histogram on the right, majority of patients are diagnosed 65 years or older. This is only going to get worse in the future with the baby boomers reaching 65 years of age or higher, and the population demographic change that the United States is undergoing right now. Second, older adults with multiple myeloma have poor outcomes. We and others have shown that older adults with myeloma have much inferior survival as compared to younger counterparts. The problem is that chronologic age by itself, as well as performance status, which is commonly captured by clinicians during routine cancer care, does not adequately explain these adverse outcomes seen by certain older adults. Prior research has shown that a geriatric assessment, which is a comprehensive evaluation of the health status of an older adult, can capture aging-related vulnerability. And to that end, the International Myeloma Working Group came up with the Geriatric Assessment-Based Frailty Index to define patients as fit, intermediate, fit, and frail, and really be able to predict the outcomes of older adults in terms of both toxicities and survival. The problem with geriatric assessment is that it's not utilized. In this survey, in a survey conducted by the American Society of Clinical Oncology last year, only 20% or fewer clinicians were actually using geriatric assessment in routine clinical care. Time and resource constraints were the two most commonly cited reasons for not using geriatric assessment. Therefore, there is a need of easily obtained tests and biomarkers that can rapidly identify frail older adults at greatest risk of adverse events. One of those is the neutrophil lymphocyte ratio, which combines a marker of inflammation and immunosenescence. And you can see on the diagram to the lower bottom right that with each increasing age by decade, the neutrophil to lymphocyte ratio tends to steadily rise as a marker, potential marker of aging. Our aim was to evaluate the association of pre-treatment neutrophil to lymphocyte ratio with frailty and overall survival among older adults with multiple myeloma, 60 years and older. Our analytic plan was that we were interested, our main predictor of interest was pre-treatment neutrophil to lymphocyte ratio. We captured this using the absolute neutrophil and lymphocyte count up to 90 days before the start of first-line treatment. We then stratified the NLR into 4 quartiles, Q1 being the lowest quartile and Q4 being the highest quartile. There were 2 co-primary outcomes of interest. One, we were interested in frailty. For this particular research, we defined frailty using a validated composite score using age, performance status, and comorbidities. Secondly, we also abstracted information on overall survival with censoring of patients at their last visit in the EHR. We measured the association between NLR and frailty using logistic regression model, adjusting for age, sex, and race ethnicity. And finally, studied the association between NLR and overall survival using Kaplan-Meier methods and Cox regression analysis, adjusting for potential confounders. This is a summary of our cohort selection. We started with about 10,700 patients in the database, and after excluding patients with available and unknown neutrophil and lymphocyte count, as well as younger patients, we ended up with 2,792 eligible patients for this study. The first result, in terms of association of NLR with frailty, we found that overall 60% of our cohort were frail, and that higher NLR, Q4 versus Q1, was associated with 2.1 increased odds of frailty even after adjusting for age, sex, and race ethnicity. In terms of survival, we found differences between the various quartiles of NLR, with Q4 being the worst and Q1 being the best overall survival, and Q2 and Q3 not shown in this Kaplan-Meier plot were overlay in between those 2 graphs. In terms of Cox regression, we found increasing hazards of all-cause mortality with each increasing quartile. So Q4 versus Q1 having a 1.5 hazard ratio with statistically significant even after adjusting for potential confounders. Our limitations, we did not have any available data on the IMWG frailty index. Many argue that this is the gold standard for measuring frailty in this population. We also did not have complete ascertainment of frailty status because there was a lot of missing data on ECOG performance status. We did not impute these variables, and up to 40% had missing ECOG performance status. Lastly, there is some limitations with the capture of comorbidity data in Flatiron database, since oncologists may not capture comorbidities accurately in their electronic health record. There have been validation studies that have suggested that this comorbidity in the Flatiron database tends to have a low sensitivity. To conclude, NLR could be potentially an easily available biomarker that is associated with frailty and survival among older adults with myeloma. Future studies should explore its value as a screening tool in combination with certain other known aging biomarkers to identify frail subset of older adults with multiple myeloma. And therefore, these early recognition of frail individuals early on during their treatment trajectory can lead to appropriate treatment selection and targeted interventions. I would like to move on to my second project, which is related, and then I'll take questions at the end. So the second project is multiple myeloma in the very old, disease characteristics, treatment patterns, and outcomes in the real world. Why did we study this? First of all, older adults over 80 years are not enrolled in clinical trials. In the FDA analysis presented in 2017 ASCO meeting, FDA reviewed all the clinical trial enrollment data submitted to the FDA between 2005 to 2015, and only about 4% of this population were actually enrolled in clinical trials, as opposed to an incidence of 16% in the SEER database. Secondly, aging is a heterogeneous process. We know, and we've all seen in our day-to-day clinical practice, that the patients of the same age can have different functional status. Therefore, use of chronologic age alone to guide treatment decisions is inaccurate. The problem is then, in the myeloma literature, there are two broadly, most commonly used frailty definitions: the IFWG frailty index and the modified ECOG frailty index. Both of these indices use age, chronologic age, as an independent scoring variable to define frailty. And as you can see, just by virtue of being aged more than 80 years alone, patients can be inaccurately classified as frail. So our aims, with that background in mind, our aim was to characterize the baseline demographic, clinical features, and treatment practices, as well as survival outcomes of the very old, older adults, 80 years and older with multiple myeloma. And then we wanted to compare the survival outcomes of fit older adults, 80 years and older, versus those of younger counterparts. Again, we used the Flatiron Electronic Health Database, identifying patients between 2011 and 2020, extracted their labs, cytogenetic data, and then we compared the baseline demographic and clinical characteristics between patients 80 years and older versus younger than 80 years. And then we also computed their progression-free survival and overall survival using Kaplan-Meier methods and Cox regression. Lastly, using ECOG performance status of 0 as a surrogate of fitness, we compared the survival outcomes between 80 years and older versus younger than 80 years, using both derived progression-free survival and overall survival. So this is our cohort selection. After excluding patients with unknown age, as well as incomplete information on their first-line therapy and cytogenetics and labs, we came up with a total of around 4,500 patients younger than 80 and 419 patients older than 80 years old. Our baseline characteristics included to compare between older than 80 versus younger. Those who were older than 80 were more likely to be non-Hispanic whites, also have an impaired ECOG performance status, and a higher prevalence of comorbidities, as expected. In terms of disease characteristics, we found that those patients who were over 80 years old had a higher ISS stage, the International Staging System, as well as had lower prevalence of certain high-risk cytogenetics, particularly the IgH translocations. This has been documented and reported before in smaller studies. In terms of disease and treatment characteristics, we found a higher overall median beta-2 microglobulin in this population, as well as as expected, less use of intensive triplet therapies and more use of doublet therapies in this population. As expected, very few patients over the age of 80 underwent stem cell transplantation. In terms of survival, no surprise that we found that the outcomes both in terms of derived progression-free survival as well as overall survival, were inferior in patients over the age of 80 years. What was also interesting was the 6-month mortality rate was very high, up to 20% in the older age group versus 6%, which was statistically significant. Using ECOG performance status as the fitness, as a surrogate for fit older adults, when we compared 80 plus versus 75 to 79, we found that the progression-free survival as well as overall survival were virtually identical, arguing that using age alone to classify these patients as unfit is not accurate. Some of the limitations here we faced was we had a very high level of missingness with ECOG performance status. I already touched upon the suboptimal comorbidity capture. We could not do a frail by age alone versus frail by others analysis because of some concerns over these variables. And there were some issues with truncation of patients born before 1934. And we used some methods to overcome those limitations. Some of our ongoing future work include, we are interested to continue this work and incorporate additional routinely collected laboratory variables, ideally to define an EHR captured frailty prediction algorithm that can really be used to identify frail patients more accurately and in real time. I think we are also interested in terms of the disparities in clinical trial enrollment faced by older adults with myeloma. So we have some planned work in that regard. We're also examining some of the eligibility criteria of all the registration trials for multiple myeloma, as well as CAR-T studies, and how that reflects in the real world. And lastly, we've used Flatiron for several other instances to use to rapidly generate some pilot preliminary data for some of our future grant applications. Briefly talking about how to request a Flatiron data set for those that are interested. This is a resource that is available to UAB investigators for free as a part of Flatiron's academic partnership with UAB. UAB is a data contributor to this database, and there is a form, there is a portal that can be used to submit and track proposals, and also learn about some of the methodology. This is my final slide. I would like to acknowledge my funding sources, ICOS, which has been my home for the last 2 years. My mentor, Dr. Bhatia, most importantly, our care team, our 2 wonderful CRAs, Diana and Claire, Grant, who's been a colleague and a mentor, as well as our UAB multiple myeloma team. Thank you very much, and I would like to invite any questions.
So while others are getting ready, Smith, I truly have enjoyed these 2 projects that you've developed, and also how you've developed your skill set in utilizing the Flatiron. Now, we do understand that it has, as does any real life data, have problems. It's always fraught with issues. It's not perfect, otherwise it would be similar to a clinical trial. So having said that, it might behoove us to really dig down and think, what would be the most appropriate use of the Flatiron data set? Because there are some values which EHR also cannot fudge. They're not dependent on physicians entering them or not, such as lab values. The outcomes data, I worry about that because it's so dependent on patients getting lost to follow-up, patients being discharged and not knowing what the long-term outcomes are. Because when you look at your survival curves, there is attrition. They very rapidly taper off the numbers at risk. So it really would be good to see what can we do in order to take the maximum advantage of Flatiron? So that wasn't a question, it was a comment, but I really appreciated your talk. Thank you.
Thank you, Dr. Bhatt. Great comment. I completely agree with you that there are some real problems with EHR data. And there are some unique advantages, but there are certainly problems. I touched upon a little bit about comorbidities because it turns out that oncologists do not really do a good job recording comorbidities in their notes or capturing that information. So that has led to a lot of capture of patients with comorbidities, which is a real problem in older adults, the population that we want to study. And so there has been some challenges, certainly. And I think there needs to be some carefully thought out questions that kind of maximizes the available data and minimizes the limitations.
Smith, one question, really cool talk, innovative use of this data set. Talk about the missingness in the Flatiron data. What do you find is more reliable, or what has more missing data? And do you find yourself needing to think about imputation for some of these studies?
Yes, the major problem with any EHR data, this is true for Cancer Link. If you go at ASCO, if you look at, I'm sure Dr. Kenzik can speak about Optum. ECOG performance status is not captured, and I myself share the blame because we do not do a good job recording ECOG performance status where we don't have to, where patients in a clinical trial, patients not enrolled in trials, people constantly sending us reminders to document ECOG performance status. We don't do a good job of recording that, and that's a major, in my experience, is a major area of missingness, with up to 40% of patients missing ECOG performance status. I think that's one thing. The other potential problem I see is, as Dr. Bhatia also pointed out, is that these data is only coming from an oncology practice. There is no integration of these practices with, let's say, primary care or hospitals or cardiologist office notes. So what that means is that if the patient decides to leave that clinic and go on to a higher level of care for clinical trials or kind of relapse treatment, they will be lost to follow-up, and they will just fall off the survival follow-up. So those two are in my opinion, the biggest problems with this data set. And I think one of the things that we did was we did not capture. We actually censored patient at their last structured visit. So if they fall off, let's say they started in 2011, but they fell off at 2014, even if the data was cut at 2021, our end of follow-up would be 2014 because the patient was not seen after that. So that's that could be a major source of bias. And when we started working with this data set, that was in 2019, there was not a lot of methodological guidance, but they have really done a good job, the Flatiron team, of doing a lot of tutorials. There are R codes, there are even packages, macros built to extract specific variables. So there is a lot of analytic guidance now than what existed 2 years ago that can really help investigators overcome some of these biases.
Any other questions? Smith, are there any plans are you friends with the people who are higher ups in the Flatiron databases?
They have, yes, I used to know a lot of them. When they started, the company has undergone a major kind of leadership or organizational restructuring. It seems like people are leaving and a whole new team has joined. I do know a few people. Having said that, I do know, Neil Miropol is a well-known oncologist who is a sort of vice president and senior director Amy Abernethy, who's a well-known an outcomes researcher, used to be the chief scientific lead, has now moved on to go to FDA.
Right.
And I think that the new person is a pharmacoepidemiologist from University of Illinois in Chicago. I'm blanking on his name, but he seems really nice as well.
Well, the question then comes up is, would they be interested in linking with other databases, you know? So for example, linking with National Death Index or linking with other sources of data in order to really fill those holes that are there.
I think the short answer is yes. They have shown that they are interested in expanding and linking additional data sources. One thing that I did not touch upon is that has happened very recently is that they have linked their data with Foundation One. So there is a vast clinical genomic database now in lung cancer and some other cancers that is available to researchers. So they are clearly interested to link and expand their database. Now, what I do not know is how much of that is guided by financial, incentives, because academic research is just a small portion of their portfolio.
Yes.
They have Roche is the company that owns the data, and their business model is basically selling of these data to companies and industries that are using these data to support their drug approvals and parallel RWEs for their drug applications.
Yes, I understand that.
I would also make a quick comment about the death index. They have actually validated to some extent their overall survival capture against Social Security death index, and it seems quite accurate.
Yeah, and SSDI is actually really fallen out of favor now because of a variety of issues. So I wish they would do it with NDI or even with SEER. If they could, link it with SEER, that would be a simple thing to take care of for the overlap.
I think one of the big questions, and we've had this conversation when we've tried to work with Optum too, is at what point the identifiability issues, and so like their liability in terms of how much they can link. And let's say they can link everything, but then you as the researcher are never going to get all of it, right? So there's going to be a trade-off between the linkage, whether they're allowed to or not, or whether they have the finance, like you said, the motivation to do it. But it depends on, are they going to allow other people to get it or only parts of it?
Well, so the thing is that they can always link it and serve as honest brokers over there at their end and give de-identified data to you.
If they're motivated to do that.
If they're,
I guess.
That's the big question. Yeah.
Yeah, one thing that people are really, I know they are working on is that they are trying to link clinical trial participants and capture the longitudinal data beyond active trial follow-up to ensure to get some of that longer term trial follow-up data, which is cost saving and
but that is so fraught with, if they were to send that to me to review, I would kill that paper because of the issues of the rigor needed to follow people completely long term. So that is a big thing with them. Yeah. Anyways, we need to stop here, Smith, because we need to give Kelly a bit of a chance to speak.
Thank you very much.
Yeah, thank you. So now it's my pleasure to introduce Kelly. Kelly came to us in 2015 as an assistant professor in HEMONC and a member of the Institute for Cancer Outcomes and Survivorship. She, from the time of her Bachelor's of Science through her PhD, was a University of Florida kid, and then moved here to do a T32 in 2013 postdoc with Kenzik's program in Health Services Outcomes and Effectiveness Research and Education. And that's where Ken said, hey, you want a brilliant kid? And I said, yes. And we've never looked back. Kelly writes a wonderful statement about what her major research interests are, and I really liked it, how she put it together. And I will read it verbatim so people know exactly what she's doing. So my primary research interests, Kelly's, not mine, include using advanced methodology to examine short and long-term outcomes among patients with cancer. This involves the integration of clinical, administrative, financial, geographic, and biologic data, as well as patient-reported information to inform clinical decision-making, policy development, and interventions for improving cancer care and patient outcomes. So this is a very brief capsule of what she does, which has yielded over, again, 80 papers in press, under review, or published. She has recently received a fundable score for an R1 application submitted for the first time. And she's well on her way to show us how she can harness information from a variety of sources in order to address the questions that she's asking. Kelly, take it away from here.
Thank you very much. Am I showing the right screen for everybody?
Yes, you are.
Perfect. Great. Thank you so much, Dr. Bhatia, for the introduction. And it's always nice to be able to present one of these research projects more than once, right? So we get some more use out of how much time we put into these. So the project I'm going to present was from my American Cancer Society award project. And it's on hospitalization patterns and Medicare spending for non-malignant morbidity among older survivors of non-Hodgkin lymphoma. So the most recent survival data estimates that the 5-year survival rate among older adults diagnosed with non-Hodgkin lymphoma is 65%. There have been continued improvements in survival over the past 2 decades, and you can see that reflected in this graph of mortality rates among older non-Hodgkin lymphoma patients. And this declining mortality trend has resulted in over 430,000 individuals who are over the age of 65 that are living with a history of non-Hodgkin lymphoma. So older patients with NHL are at particularly high risk for treatment-related morbidity, in addition to the morbidity that they have that's associated with aging, much as to what Smith alluded to earlier. The combined impact of treatment-related effects and aging can result in a more complex patient. The management of these patients can potentially present an additional strain on the healthcare system, and this includes both in terms of utilization and spending. So in order to create effective risk-based models of care to provide adequate care for these patients, we need to examine and understand current utilization and spending patterns. So the goal of this study was to examine cumulative burden of chronic and acute health condition-specific hospitalizations and the Medicare spending associated with them, and also to compare this to a non-cancer cohort. We also aimed to examine factors that were associated with high hospitalization rates and high spending. So to do this, we used another real-world data set, the surveillance epidemiology and end results data, which I'm sure many of you are familiar with, and this was linked with Medicare administrative claims. It also provides a non-cancer sample randomly selected from Medicare. So this is strictly based on billing data and what is reported to Medicare in terms of reimbursement, and then combined with our National Cancer Registry data that captures about 28% of the US population. So our eligible cohort was incident NHL cases diagnosed between 2008 and 2015. We wanted everyone to be at least 66 years of age at diagnosis to ensure that we had at least 1 year prior. We wanted at least 6 months of continuous Part A and B coverage with no Medicare or Advantage enrollment. We also wanted them to have received a treatment within 1 year of diagnosis. We did not want to include some of the watch and wait because we wanted to see actively treated patients. We were followed these patients until 5 years, the end of study. We censored them if they had a bone marrow transplant, loss of coverage. And then we also censored at 6 months prior to death so that we did not capture end of life care. We wanted this to be sort of in the survivorship component. In the comparison population, it was assigned a pseudo-diagnosis date, and we selected them to provide a population match based on age, race, sex, and their available follow-up time. So our outcomes included hospitalizations for new onset non-malignant morbidity. And when I say non-malignant, I'm referring to non-treatment. So these are not hospitalizations or outpatient visits that are designed to be actively treating the cancer. And we looked at these over the first year and also over the first year and then 5 years from diagnosis. And we defined new onset morbidity requiring that they did not have this particular diagnosis in the year prior to diagnosis, prior to cancer diagnosis. We use ICD-9 and 10 codes on the first or second position on the claim to help characterize the reason for the hospitalization. We had looked at 109 different conditions grouped into 10 categories, and these were informed from the CTCAE, Charlson, Elixhauser. And these 10 condition groups were cardiovascular, gastrointestinal, pulmonary, neurological, renal, endocrine, immune-related, psychological, behavioral, and age-related, which we eventually modified to be more age/treatment toxicity because it included things such as anemia, dehydration, and weight loss. So pending the reason for the hospitalization, those could either be post-treatment related or related to aging. So our second outcome was Medicare spending, and we used the amount that was reimbursed to Medicare for our spending calculations. And this was the spending for all of the inpatient stays for the 109 conditions, also grouped into the categories. So the risk factors that were assessed for both the non-cancer cohort and the NHL cohort included age, sex, race, ethnicity, and precancer comorbid conditions defined using the Elixhauser. And then for the NHL only group, we had a little bit extra information from SEER that included urban rural residents, census tract education, and census tract median income, as well as their, from the claims, we were able to get their therapeutic exposures. So to compare the hospitalization rates between the NHL cohort and the non-cancer, we estimated the mean number of hospitalizations per 100 person years occurring at 1 year from diagnosis and then over the entire 5 years. So we were able to see that initial spike and then kind of capture the overall 5-year period. We calculated the incident rate ratios overall and for each of the 10 morbidity categories. And then among the NHL patients, we examined specific predictors of the hospitalization rates. And then finally, we use the predicted hospitalizations to create sort of a highest percentile group for a high hospitalizations. And then we also looked at a high spending group. So these we examined using a modified Poisson regression models to look at the risks of being in one of those groups. So for hospitalization spending, we examined the spending for the hospitals as we defined previously. Similar to the hospitalization rate, we estimated the 90th percentile. And we used that to calculate our high spend group. And then we also looked at the predictors associated with being in this high spend group. It's using a similar approach. So the non-Hodgkin lymphoma and non-cancer cohorts were similar in age distribution with about 26 to 27% over the age of 80. 52% of the cohort was female, and both samples were largely non-Hispanic white, which is pretty consistent with our incidence of NHL. 35% of the cohort was diagnosed at Ann Arbor stage 4. 60% of the patients were diagnosed in the more recent era, 2013 to 2015. And the most frequent diagnosis was diffuse large B cell. The majority of patients received chemotherapy or immunotherapy only. And 72%, so a large proportion of patients had received steroids at some point during their treatment. And the most common therapeutic regimen was R-CHOP. So for controls, the rate of hospitalizations was 11.4 and 11.5. So in their first year, it was 11.4 per 100 person year, and it didn't change when you average out over 5 years. And then conversely, in the NHL cohort, we see that the rate was 41.7 per 100 person years at 1 year. And then averaging out over the 5 years, it declines a little bit, but it remains 22.4 per 100 person years at 5 years from non-Hodgkin lymphoma diagnosis. The adjusted models show us that at 1 year, NHL patients had a rate of hospitalizations that was almost 3 times that of controls. And then at 5 years, the rate was almost 1.5 times that of controls. And for both NHL and the controls. The most frequently occurring hospitalizations were for cardiovascular disease, which is here in the green, pulmonary, which is this orange color, and then gastrointestinal, which is a little bit of the lighter green. So consistently, those were the most frequently occurring conditions that requiring hospitalizations. And notably, while these may have been the most frequently occurring, they did not necessarily represent the largest differences between controls and the NHL patients. So the largest differences when we compare them actually occurred in this age or toxicity, we could, pending the definition related, which is the age toxicity related. So we can see here that this was, which again, like I said, includes dehydration, anemia, and weight loss. And the NHL cohort had almost 7 times a higher rate compared to controls at 1 year, and then 2.5 times over the 5-year period. So that risk maintained over the 5-year period. And then we also see an increased rate of gastrointestinal and endocrine, particularly at the 1-year mark. When we look at the predictors of the hospitalizations in the NHL cohort only, the factors that were associated with a significantly higher rate of hospitalizations over the 5 years, these included older age, prior comorbid conditions, non-Hispanic Black race, residing in an area with low education, diffuse large B-cell diagnosis, stage 4 diagnosis, receiving R-CHOP or some other rituximab regimen, and then being diagnosed in the later era. And these results are consistent if you were to look at them based on year 1 only. So now when we look at the predictors of being in that high hospitalization group, that in the greater than 90th percentile, in the NHL cohort, again, we see factors associated with this are age, comorbid conditions, non-Hispanic Black race, areas of low education, diffuse large B-cell, stage 4, and then in this one, also residing in a low income area, residing in a rural area, later year of diagnosis, and then having the chemotherapy, a chemotherapy-based treatment. So the estimated hospitalization-related spending per person year, so really focusing on the amount of time, here was about 2,000 for NHL patients compared to approximately 1,600 for controls. So this is per person year contributed to the study. And we see that those related to cardiovascular morbidity was associated with the largest spending, followed by gastrointestinal, pulmonary, and then, gastrointestinal and pulmonary were our largest differences here. So our overall spending per visit, so for if you were to compare a similar visit between the non-Hodgkin lymphoma and the non-cancer, it was higher for the non-Hodgkin lymphoma cohort at about 17,000. This is on average per visit compared to 14,000 for the non-cancer control. And again, we're focusing here on non-treatment delivery visits. And then when we kind of further dug into this, we found that the most expensive hospitalizations were related to chronic kidney disease, and then subsequently to pulmonary complications. So those were kind of the two heaviest hitters for the most expensive. When we look at the predictors of the high hospitalization spending, we see that, again, being older contributes, having more comorbidities prior to diagnosis, non-Hispanic Black race, diffuse large B-cell, stage 4 at diagnosis, low education, low income, later years of diagnosis, and then the chemotherapy contributed. So overall, we found a significantly higher rate of non-malignant hospitalizations over the first 5 years from diagnosis for NHL compared to their non-cancer counterparts. This was definitely most pronounced in the first year from diagnosis. The most frequent hospitalizations were for cardiovascular conditions. However, the largest difference that we observed was for the aging-related gastrointestinal, endocrine, and then followed by cardiovascular conditions. Spending was consistently higher for NHL compared to the non-cancer cohort, and per person year hospitalization was highest for CVD, and then per visit, it was actually highest for chronic kidney disease. We identified several important characteristics of both the high utilization and high spending. And then in addition to these factors, we found that rural and low income were associated with high spending only, not necessarily the visit rate. And, to kind of piggyback off of what Smith was saying with our limitations, administrative data has its own limitations. Administrative data is designed for billing purposes, so we lack any of the context that may be delivered via EMR, in contrast to what we might gain by having greater follow-up or prior data. This data only includes fee-for-service Medicare patients and not the Medicare Advantage or HMO patients. There's always a risk of unmeasured confounding in these large-scale databases. So finally, despite these limitations, we do have some big observations to take away. And while they not only experienced a greater number of hospitalizations, they did have greater spending. And post hoc analysis found that this was not necessarily attributable to length of stay. They had similar lengths of stay. It was likely representative of greater complexity. We did a check with a greater proportion of visits with the DRG codes indicating multiple comorbid conditions with greater complexity, which is then a higher bill rate for Medicare. Second, we did find some notable characteristics in clinical and patient characteristics. And these included diffuse large B cell, Black race, rural, low income. And it's important that we will look further into, that's part of hopefully the grant that will come through. We'll get to look at these issues at a more multi-level, from a more multi-level view to kind of understand how these are associated. And then finally, all of these findings emphasize the need for a more specialized or risk-based care. If these conditions can be identified early, they can be kind of managed upfront to prevent some of these hospitalizations. It also speaks to how multidisciplinary clinics may facilitate the mitigation of morbidity. And some of the other ways we can use this risk-based care is we can employ additional care coordination, which may include navigators, health workers, social workers, greater involvement of primary care. And then also including making sure that things like geriatric assessments that are coupled with measures of social determinants of health are included, so that we can better understand the personal risk for morbidity, as well as some of the challenges that may arise due to socioeconomic status and by the high burden of morbidity. As an update to this, we did just publish this in the Journal of Geriatric Oncology. And then for this paper, we added everything that you saw in terms of the outpatient visits, pretty consistent findings with higher rates. We did notice some differences in terms of which conditions for outpatient were more important, which included a lot of endocrine and renal. And then rural areas were very important for higher rates of outpatient utilization, which is not surprising. And then the magnitude of spending was less, although it was still greater for NHL, and we saw similar risk factors. So with that, I will end and thank all of the collaborators, colleagues. I know this was a long-running project for a long time, but I really appreciate all of your help, and thanks for your attention.
Thank you, Kelly. Any questions for Kelly?
Can I ask one question?
Yes, Smith.
So, you've seen great work, first of all, very interesting. For the cardiovascular, it seems like cardiovascular hospitalization is quite significant. Mm. And, one thing that we always tend to think is doxorubicin, cardiotoxicity and all that. In the lymphoma world, we don't tend to use the very high doses, cumulative doses. And so that, the kind of the traditional thought is that, we don't expect to see a lot of cardiovascular complications from doxorubicin. But what were you, what could be the source of such a high cardiovascular risk with seen in your population?
Yeah, so I think the important part to kind of remember for the cardiovascular is that while it was high, it was not our biggest difference between the non-cancer cohort. So it's a little, it was still a little bit higher, and I agree that it's less, that it's less, it's not happening as much in a greater capacity relative to them, but it's still, they're still identified. And it could be the fact that maybe they're just being seen more frequently. I don't know, like maybe they're showing up more often in the hospital and having more issues related to that. But I agree that it's not necessarily one of the primary ones that we see. They could just be having a greater distress due to any, hospitalizations for treatment, right? Like that's a stress on the body after the fact. And if they end up with dehydration, anemia, then their blood pressure goes off, like it could just be sort of the trickle down effect, which again is something that we can't necessarily find in claims. You can see that more in EMR and sort of the source of it. But it's not the greatest difference. There is a difference, but it wasn't the biggest gap between the non-cancer cohort.
Right. So my second question is that, you saw that DLBCL was one of the highest, kind of spending wise, risk wise, the significant risk factors. Diffuse large B-cell lymphoma treatment usually involves an intensive treatment in the beginning, about, kind of 4 months of treatment. And then most patients are expected to get long-term remission, 50 to 60%, they enter the survivorship phase. Did you see, like, in terms of like these phases of treatment, it seems like you are seeing hospitalization rates both in the initial phase, but also once they come off the chemotherapy, are they still continuing to be, kind of spending a lot of money, or, healthcare utilization wise? Did you do that analysis?
Are you talking about like the one, what are you referring to? Like,
once they come off the active chemotherapy and enter the survivorship phase, which is kind of tricky to define in claims, but still, you see that there is no more place for.
So that's kind of why we did the look at the 1 year, right? Because everything that we looked at was excluding any of their treatment, right? So we wanted to see, kind of irrespective of whether they were on treatment or not, to see whether other things were happening. But we did think it was important, like you said, to characterize that first year, because those could have other short-term effects. But over the 5-year period, yes, it was still higher than the non-cancer cohort, but the magnitude was less. So it still existed, it was just to a lesser magnitude. It's mitigated over time, but we did not explicitly look from the completion of therapy forward. Like we didn't like do that exact cutoff, because we were excluding any claims related on treatment. So.
Thank you.
Kelly.
Yes.
So this has been my constant discussion with you is, can we use these data that you've generated in order to identify people where we would say that we would do risk stratified care of the individuals? So if you go back to that wonderful slide, which is, which one am I talking about?
This one?
No. Well, yes, but go back to your bars with those cause-specific hospitalizations, the 109 conditions. Yeah.
This one?
So here, what you're seeing is, just look at the right side panel. And if you were to do something along the lines of, so you have 1 year hospitalizations, but then you have 5-year hospitalizations. And what we could do is to look at 1 to 5 years, so year 2 to year 5 hospitalizations, and see what are the causes of those hospitalizations, and then look to see what are the predictors of those hospitalizations, year 2 to year 5. And then go down now to that slide, which was your summary slide. Oh my goodness, I'm going to make you do this. Yeah, and so here, what we are seeing is that you've already identified a group of people who would benefit really from being kept close to the oncology service and followed closely in a multidisciplinary survivorship clinic, versus those who can be sent out to the PCPs and followed long term. So if we combined or created an and/or situation for these characteristics, you would identify a group of people a no-brainer, of who are requiring a tremendous amount of hospitalizations, and a group of people who have none of these conditions would require very minimal hospitalizations. And so that would be the summary that you could create of a risk stratified care model, which you would say, which you would inform the lymphoma oncology community to say, 1 year post-diagnosis, from year 2 to year 5, if you have any of these conditions, keep them close to you. If you have none of these conditions, send them out, because look at my data. It shows that there's minimal hospitalizations for those patients who have none of these conditions. Will you do that?
Yes, and that's currently what we're doing in the colorectal
For colorectal
population.
cancer. Exactly. So this is what you want to do systematically but doing it from year 2 to year 5, not over a period of year 5 years from diagnosis.
Yeah, so this is on average over the 5 years.
Right.
Yeah.
Because 1 year they have to stay with the oncologist. It's from year 2 onwards where they discharge them all. But who are the ones you want to discharge, and who are the ones who you want to keep close to yourself? And then developing models of how much money would be spent in keeping them close, how much money would be saved in keeping them close versus sending them out. All right, I think we've run out of time. Kelly, thank you so much. Smith, thank you so much. And everybody, thank you so much for joining us for this really nice session. Bye, guys.